Good evening. Thanks for this opportunity to present these two abstracts. So the first abstract that I'll be discussing came out in the JCO last year. So this was an update of the STEEP criteria, which looked at defining endpoints in adjuvant breast cancer clinical trials. So the background for this study is that these STEEP criteria were established in 2007, and these aim to standardize definitions of adjuvant breast cancer clinical trial endpoints. So most breast cancer trials use an endpoint of IDFS, which is invasive disease-free survival. At that point, the thought process was that this was less ambiguous and it excludes in situ events. But with time, with advances in diagnostics, with IHC markers and recurrences being more diagnosed more often with pathological confirmation, and also with improvement in management and increasing recruitment of older patients, and thus thereby with an increase in the likelihood of a non-breast cancer related mortality, there seemed to be a tendency to relook at IDFS. So the basis of this study was to actually to reassess these STEEP criteria and also to go back and assess adherence to these criteria in the adjuvant trials which have been performed since 2007. So the study methodology is that all phase 3 adjuvant trials published after 1st Jan 2008 were assessed for utilization of these criteria by a panel of experts, mostly based in the US. So they identified 11 adjuvant phase 3 clinical trials, and out of these, 3 were fully compliant with STEEP. 4 used the STEEP definitions, but not the corresponding endpoint names. So they used the STEEP IDFS, but called it a DFS, and 4 used definitions which were totally not included in the STEEP. And then these trials were classified into 5 categories. So these were classified into first superiority trials, then trials looking at local therapy, endocrine therapy in low-risk populations, and non-inferiority trials. So this table actually shows us the 11 trials which were assessed for adherence to the STEEP version 101. So when we look at superiority trials, what they found is that the most common deviation was that they in the IDFS was that they exclusion of a second non-primary breast cancers. And all 3 trials which excluded this examined addition of new targeted agents to chemo and also trastuzumab for early breast cancer. Now, inclusion of this as an IDFS event may actually identify treatment-related events like, for example, tamoxifen leading to a uterine cancer, and also avoids missing distant recurrences, which would have sort of otherwise been treated as a second primary. So what they went ahead and did is that they did a modeling based on the IDFS, and they took one trial as an example, one superiority design trial as an example. So what these trials' statistical assumptions were was that to detect a 95% 3-year invasive breast cancer-free survival in the experimental versus 92% in the standard of care, the rate of second non-primary breast cancers was assumed to be 1% in the standard of care arm, and they did a modeling where they looked at the rate of 0.5, 1, and 2% in the experimental arm. And what you can see on the right, the blue line represents the hazard ratios if you use IBCFS as the appropriate endpoint, and the red lines actually represent what happens if you use IDFS as the appropriate endpoint. So the IBCFS is the hazard ratios are pretty much standard irrespective of the incidence rate of second non-primary breast cancers across the board, irrespective of whether it is 0.51 or 2%. Whereas the hazard ratio for the IDFS varies with differing rates of second primary diagnosis. So this highlights the challenge of incorporating multiple events in the same endpoint. Therefore, it is not possible to distinguish which event is driving the differences between arms. And also inclusion or exclusion of these events from the primary endpoint can thus lead to a dramatic effect on the inferences in the trial. Similarly, in the non-inferiority design, where you would, most non-inferiority designs are in trials where the populations are low risk, low event rates are there. Here also there is a similar result of, there is an increased chance of falsely inferring non-inferiority. So here also there is a reason for consideration of IBCFS or relapse-free interval rather than IDFS. So what the STEEP version 2 proposes is that it proposes that we use the invasive breast cancer-free survival mostly as an appropriate adjuvant endpoint, especially in trials where the events that contribute to the primary and secondary outcomes are adequately adjudicated. Now, a word of caution by the authors. in the low resource settings, which probably sometimes us also. So this may not be the optimal primary endpoint if follow-up imaging diagnostics are not accessible to most patients. And this also stresses upon the need for long-term follow-up in order to monitor late events and toxicity. Now, when we move on to locoregional therapy trials, the IBR, which is the ipsilateral breast cancer recurrence, is what is recommended as the appropriate endpoint. Now, in special considerations for endocrine therapy trials in STEEP version 2, we know that endocrine therapy alters incidence of contralateral breast cancer, and therefore there is a need to include this in the primary endpoint. And also here we need to, higher toxicity would lead to a higher discontinuation rate if there was evidence that this intervention didn't prevent distant recurrences. Therefore, it is vital for us to use a DFS as an endpoint with prevalence of each event type, that is ipsilateral, contralateral, and distant recurrences. For low-risk populations, because of low event rates or large sample size, sometimes we may be using single-arm trials. For this, a good example of this is the APT trial in HER2-positive early breast cancer. In this setting, IDFS may capture events like a new contralateral primary cancer or a non-breast cancer-related death, which actually do not reflect disease recurrence. And also, in the setting, where we include older patients, there is also a clause where we could include all-cause mortality also. So to conclude, the selection of an appropriate multi-event primary endpoint in adjuvant breast cancer clinical trials is crucial. So when we look at superiority trials, invasive breast cancer-free survival is preferred over the traditional IDFS if we know that the intervention that's being assessed is not known to cause second non-breast cancers. But despite this, we should still monitor for second non-breast primary cancers and report them as part of a standard IDFS. And when we look at endocrine therapy trials, DFS is a reasonable endpoint, but remember to report the prevalence of each event as ipsilateral, contralateral, and distant recurrences as per the study arm. In low-risk trials, recurrence-free survival may better describe the event rates in this patient population, and IDFS can be reported as a secondary outcome. When we look at non-inferiority trials, again, IBCS or recurrence-free survival is an appropriate primary endpoint. And for breast cancer surgery and radiation therapy trials, ipsilateral breast recurrence is the approved primary endpoint. So this is the end of the first abstract. We will move on to the second abstract. So the second abstract for consideration is, again, a retrospective analysis from Sweden. So this is assessment of the 25-year survival of patients with estrogen receptor positive HER2 negative breast cancer who were treated between 1976 to 1990 with tamoxifen. So the background is that we don't know much about the association of our traditional clinically used breast cancer markers like the T size, the tumor grade, PR positivity, and Ki67 with long-term breast cancer-related survival outcomes. We know what it does to the short-term outcomes, but we don't really know what these do to the long-term outcomes. So the study methodology, this is actually a secondary analysis of a randomized control trial called the Stockholm tamoxifen trial, STO3, and this was done in Sweden. So the patients were postmenopausal women with node-negative breast cancer, ER positive, and HER2 negative. And they had already completed 2 years on tamoxifen. So the intervention here was adjuvant tamoxifen for 3 more years, and the control arm did not receive any more adjuvant treatment. The outcome which was assessed was distant recurrence-free survival as per the STEEP version 1. And patients' complete follow-up was obtained as on December 2016 from the Swedish National Registry. And in this trial, obviously, they had to redo the IHC in 2014. So they considered a more than 10% threshold for ER/PR positivity. A high Ki67 was considered to be anything more than 15%. Out of the original 1,700 odd patients in the study, all this information was available only for 565 patients, and that is those patients consist this analysis. So the outcomes they studied were the distant recurrence-free interval as per the Kaplan-Meier method, and they looked at the effect of clinical markers on the recurrence-free interval. So when we look at the first thing, which is the tumor size, which is panel A, so what we can see is that tumor size in terms of the long-term distant recurrence-free survival. And so patients with a lower with T1AB had a better outcome. With similarly with grade 1, grade 2 tumors had a better outcome. There was no significant difference in terms of PR status and Ki67 status. In multivariate analysis, what they showed is that there was a better reduction in distant recurrence among patients with larger tumors, T1C, T2, or grade 1-2 tumors. They also did a recursive partition analysis, and what they showed here is that the worst outcomes were associated with patients with larger tumors who had a T2 tumor. So to conclude, among patients with node-negative, ER-positive, HER2-negative breast cancer, from the STO3 RCT, tumor size followed by tumor grade was significantly associated with the worse long-term risk of distant recurrence. And patients with larger tumors and a higher grade had worse long-term survival outcome when you compared them with T1A or T1B tumors. PR status and Ki67 did not significantly affect the long-term recurrence-free survival in patients with node-negative, ER-positive, HER2-negative breast cancer. Thank you.